Okay, so today we're going to discuss something about paracetamol poisoning. So, as we all know, paracetamol is probably the most commonly used drug on the market. So, and unsurprisingly, if taken in large doses, it is one of the most common types of poisonings that you will actually see. So, it's basically divided into two types. That is, suicidal, so large deliberate intake versus unintended poisoning that can be happening with something called RSTI, that is repeated suprathreshold ingestion. So, basically, the cutoff for the total amount of paracetamol that can be safely taken per day is around 4 grams. So if you're taking more than four grams of paracetamol per day for a long time, for more than like 3 days, that can lead to toxicity and liver dysfunction. So that is another type of issue, and that is kind of a little more difficult to diagnose because the history might not always be very obvious when it comes to that one. Pharmacokinetics, what you basically need to understand here is that usually the absorption is very good, 100% bioavailability, and usually the absorption will happen within 4 hours. So that is why when you learn something about the Rumac Matthew normogram, then the cutoff starts from about 4 hours. So that is the logic behind that one. And the occasions where the absorption is actually delayed is when if you're having some other co-ingestions like opioid or something that actually delays gastric emptying. So, in order to understand paracetamol overdoses, you unfortunately have to learn this pathophysiology and what actually happens to paracetamol in the body, also called acetaminophen. So that is why it's called APAP here. So very little of the paracetamol that you take is actually excreted unchecked in urine. Most of it, 90% of it is actually conjugated with glucuronides or sulfates, and that is then that is a non-toxic metabolite. So that is actually the good thing. So 90% of it is actually dealt with that way. Now, the problem is the other 10% or so, which is mainly dealt with by the CYP enzymes in the liver, mainly CYP2E1. And it forms a toxic metabolite called NAPKI. I'm not going to try and expand what that full form is, but basically this inter is a toxic intermediate. And if there's one thing that you should remember from this lecture, from a theoretical point of view, is this NAPKI thing, because that's the basic thing that does all the damage to the liver, and it causes hepatocyte necrosis. And if you're recalling from your MBBS and PG entrance preparation days, it affects the zone 3 of the liver, centrilobular necrosis. So that is the main problem with paracetamol overdose, leads to liver failure. So the SNAP key is then can actually be neutralized by something called glutathione, and it will help you form non-toxic metabolites again. So normal liver will actually prevent this necrosis from happening by forming non-toxic metabolites with help of glutathione. So by looking at this image, then you can figure out patients who are at risk of worse outcomes with the paracetamol overdoses. So, a patient with Gilbert's disease. Gilbert's disease is a very common condition. I think if you are having MBBS batch about 100 people, at least one or two of you would have had Gilbert's disease. It's very common. So because then the there's a slightly decreased capacity for glucuronidation or sulfation, but that is not clinically, you're not going to be able to figure that out. More importantly, some drugs. If you have some drugs that is actually inducing the CYP2E1, that will actually make things work. It will help form more and NAPKI, which is not good. So there are some anti-tuberculosis drugs and some anti-epileptics which can do this. Things that can actually deplete glutathione. Things that are actually deplete glutathione, like malnutrition and chronic alcohol ingestion, will again make the patient more at risk of toxicity. So these are some of the main clinically important things that you should take away from this. So what are the things increasing the risk is, again, as I mentioned, Gilbert's disease and the CYP2E1 inducer. So basically, rifampicin, isoniazid, very very commonly used ATT drugs, and antiepileptics like phenytoin also. So uh, so one thing that I didn't realize before I actually started preparing for this topic is that actually CLD is not, it's kind of a controversial risk factor for PCM toxicity. Of course, the maximum dose that you can give in patient with CLD is not 4 grams, it's going to be 2 grams if the patient has a CLD. That is one thing. But if the patient is not having CLD, which is not related to alcohol intake, it doesn't actually increase the risk of paracetamol toxicity by some complex mechanism that I'm not actually going into. You can read that up if you are actually interested. But most of the CLD, which is alcohol related, is obviously going to put you at an increased risk of PCM toxicity. Stages of PCM toxicity. So, when you are reading up this topic, one good thing is that to compare and contrast PCM toxicity with the iron toxicity, which has 5 stages. So, it will it's kind of similar. So, if you're reading both, it helps to actually remember it better. This is a little bit varying depending on the textbook you read. This I have referred Rosen's here. Up to date gives a different timeline. The stages, there are 4 stages in everywhere you read. It's just that the time cutoffs are a little bit different. Rosen mentions 0 to 12 hours here, but up to date simplifies it into first day, 1 to 3 days, after 3 days, and after 4 days. So, which frankly is a little bit easier than what's given here. So basically, there are 4 stages: pre-injury, liver injury, maximum liver injury, and finally the recovery phase. And obviously, it's not going to always be in this particular order, especially if you are having a very, very large ingestion of like more than 15 grams or something. So if pre-injury is basically the initial 12 to 24 hours where patients have some vague GA symptoms like nausea, vomiting, etc. And that is the time where the PCM drug levels which actually be useful to help guide management. That is the most relevant period for the measuring the drug levels. Second day, that is when you start getting the liver injury. Initially, there might be a small phase where the vomiting and all subsides, and after that, period where the patient gets a little bit symptomatically better, then the liver failure actually starts happening, and the AST ALT elevation usually will happen within 36 hours. If the patient is not having elevation of transaminases by 36 hours, the patient is not having a toxic ingestion of paracetamol basically. So at least by 36 hours, the patients will have will start to have elevations of transaminases. And then the patients will again have vomiting. Then they start developing right upper colon tenderness and all. 2 to 4 days is when you are actually going to get your li- uh, liver failure. And I think we are all, anybody works in the emergency department will generally know what that will look like. Liver failure, the metabolic acidosis, hypoglycemia, altered sensorium, hepatic encephalopathy, and renal failure will also generally start coming into play after 2 days in most of the cases. So this is a worst period and most critical period of the patient. And if the patient actually survives that 2 to 4 day period, then the patient goes into the recovery phase, and that will take around 1 week to happen. So this is this is a graph again given in Rosen about the how the different lab parameters get affected in paracetamol poisoning. So initially it's going to have transaminases elevation, AST sooner than ALT. Then your INR will get increased, and after 2 days is when you're actually going to renal failure with the elevation in the creatinine. So again, from Rosen's, what are the indications for getting a serum paracetamol level. So this is going to be a problem depending on your center, because in India, serum paracetamol levels are not going to be easily available in most of the places. Even here, it's not going to be very easy to actually get this. So it's given different for more than 6 years and less than 6 years. More than 6 years is similar to adults. So anything more than 10 grams, that is a toxic dose, and over 24 hours, we have to start you have to, that is an indication for checking the levels. More than 6 grams, or the patient over a 48-hour period, or patient is symptomatic. If the patient is symptomatic, you have to get the levels. And if the patient is symptomatic, generally you will start the patient on NAC. So, and in children less than 6 years, then you have the different weight-based cutoffs. I'm not going to bore you with by hurting that. You can refer it later. Coming to the history part. So, important thing is to find out the amount of injection. Obviously, the toxin dose is generally more than 7.5 grams. So, um, that is the usual cutoff where you have to start giving N-acetylcysteine. So again, you differentiate between single injection and whether it is multiple injection over a long period of time, and you look at the drug list, look for any medication that might actually complicate the issue, and any history of any alcoholism or liver disease, and you will send your routine labs as well as the paracetamol level. One thing that you have to understand is that usually lactate elevation comes with hepatic failure, and that usually happens after 2 days. That's the lactate elevation usually happens after 2 days. If you are having lactate elevation within 24 hours, that usually happens with a massive injection of paracetamol. Like if you are ingesting more than uh, 15 grams or something. That is when you have massive elevation. That is when you have mass elevation of lactate within the 24-hour period. So that is we'll come to the management of that massive injection in a little bit. So if you are generally bilirubin will get elevated, but not by more than 10. If you're having a bilirubin of more than 10, then you'll have to start considering other causes of liver injury as well. Now coming to the management and obviously it's always going to be ABCD, and coming to the general toxicological things, decontamination, activated charcoal, as usual for most things, more maximum benefit is usually within 1 or 2 hours, and if it is but this is I've referred this from, I think, the Internet Book of Critical Care, but up to date actually gives something little bit different. It says that in paracetamol overdose, you can give activated charcoal up to 4 hours. And if the patient is having massive ingestion more than 30 grams, you can give it even after 4 hours in that particular case. That is given in up to date. It's not based on a very robust data, but that is what they say. And what about gastric lavage? As per up to date, you don't have to do gastric lavage, because observational studies comparing gastric lavage uh, and activated charcoal versus activated charcoal alone had shown no difference basically. So they don't actually recommend doing gastric lavage if you're giving charcoal. But even if you do end up doing that, that's is not, nobody will say that's wrong. But again, lavage is mostly going to be useful in the first couple of hours, not after that. Coming to the Rumac Matthew normal curve, this is basically for patients who are asymptomatic or mildly symptomatic, and you are considering whether you actually need to, start the patient on a 21-hour infusion or not. So that doing the paracetamol levels in those kind of patients will help you decide that. So this is very simple. You on the x-axis you have the time in hours, and y-axis you have the paracetamol level, and then you have the lines drawn here, and the cutoffs are actually kind of different for the US and the UK. So and basically, if your paracetamol levels, as depending on the time after ingestion that you actually took and took the levels, if it is above this treatment line, then you have to treat the patient. Again, there are lots of caveats with this. If you need a good history about the time of ingestion and all. So if you are not having a good history, if you are having multiple co-injections, then this normogram is not going to be applicable. So I've taken this from the Indian book of critical care. So it is a gross approach to the paracetamol poisoning. So if the patient's ingestion was more than 8 hours ago, they recommended to just start the patient on N-acetylcysteine. Because basically the max with N-acetylcysteine, the better the outcomes will happen if you start it sooner. So if you are starting it within 8 to 12 hours or so, the risk of severe liver failure is very less. So the sooner you start it, the better. So if it's already 8 hours passed, it's not recommended to actually wait any longer. Just start an acetylcysteine. Or if you are working in a center where you cannot get, you know, lab values, and you cannot get a report within like 8 hours, then you just start the patient on an acetylcysteine and reevaluate whether you can stop that later. Then, if you're checking, you can check the transaminases and your serum paracetamol level. If it is more than 10, and sorry, if the transaminases are elevated, you just have to chart the patient on N-acetylcysteine. There's no doubt about that. If if the paracetamol levels are negative, so usually the negative is less than 10 micrograms per ml. 10 to 20 micrograms per ml is the usual therapeutic range. More than 20 is generally considered the toxic range. So if it is less than 10 and you have normal transaminases, generally you don't need to do treatment. Again, depending on the when you actually drew those samples. Then if the levels are high, more than 10, but there is no transaminitis, then you look for any other risk factors, whether it was chronic ingestion, whether it was actually recent ingestion, whether history is actually reliable, any other risk factors, basically of severe toxicity. If if it is if it is present and the acetaminophen level is not about the if all of these are negative, so none of these risk factors are present, and the acetaminophen levels are below the norm, that is the only condition where you are actually not going to give an acetylcysteine. So the only thing that you need to understand from this thing is that it's much easier to actually just give the patient an acetylcysteine, and you'll have to go through 100 loops to actually, clear the patient. Okay, this patient actually doesn't need an acetylcysteine. So coming to actual dosing, so what if in toxicology, this is one of the few drugs that has actually been shown to actually reduce mortality. It has to reduce mortality from like 6% to less than 1%, and especially it's better outcomes are if it is started within 8 hours. So, and that is mortality. So very few drugs in toxicology have actually been proven to reduce mortality. This is one of those drugs, and it has reduces liver failure by a huge amount, by almost 40 to 50% as well. So this is a 21 hour regimen, which is most commonly used. So we have to remember the total dose is 300 milligram per kilogram. So they've divided it into 150 milligram per kilogram over the first 1 hour, 50 milligram per kilogram over the next 4 hours, and 100 milligram per kilogram over the next 16 hours. And this you will dilute this in 200 ml, 500 ml, and 1 liter D5 water respectively. And what you have to understand here is that in severe paracetamol poisoning, you are not actually going to stop the after 21 hours. You are going to continue giving that third infusion at that same rate until the patient actually qualifies for stopping N-acetylcysteine in paracetamol poisoning. It doesn't stop when after 21 hours. You are going to keep doing that, and until the levels are falling less than 10, and the INR is less than 2, and that's a indication for actually stopping it. You don't stop after 21 hours. There is an oral regimen for NAC, and the problem with the oral regimen is that it will cause significant amount of vomiting, which is not good because the patient will have vomiting anyway. So, and if you have vomiting on oral NAC, you'll within 1 hour of giving oral NAC, you have to repeat that dose. So it becomes a huge headache. So this is I've given it the dosing as well, but generally it's going to be much more preferable, especially in our large volume center, to just start the patient on IV NAC. So again, this is the uh, criteria to actually stop the infusion. If the paracetamol levels are less than 10, the transaminases are downtrending. So it's like uh, once it reaches peak, if it has come down to like 50%, 25 to 50% of the peak levels, that is what is given in up to date, then you can, and the INR is less than 2.0. If all of these are fulfilled, all of these criteria are fulfilled, then you can consider actually stopping the patient's infusion. Otherwise, you'll have to keep continuing that. One thing you have to understand is that you can very often get some allergic reactions, sorry, anaphylactoid reaction with N-acetylcysteine. These are actually not allergic reactions. These are not IgE mediated, and generally, you should not stop N-acetylcysteine if you see. You should not stop the N-acetylcysteine completely if you see these reactions, because there have been case reports where people have gotten scared before because of the reaction, stopped N-acetylcysteine, and patient had died of liver failure, which shouldn't be happening. So if the only patient is flushing, then you don't actually need to stop the infusion. You just continue the infusion and monitor. If the patient is having urticaria, then you can give antihistamines and start the patient on steroids. With angioedema, you'll have to stop the infusion for at least 1 hour. Give them steroids, antihistamines, and see. With the patients having anaphylaxis-like symptoms, respiratory distress or hypotension, then you'll have to give epinephrine as well, and then you'll have to withhold infusion for at least 1 hour. But again, it's not recommended to completely stop the infusion because it is something that actually reduces mortality, and it's a life-saving drug. So kind of like snake bite, you'll have to find some way to actually continue giving the infusion. But again, this is not an allergic reaction. This is not IgE mediated. So there are other regimens. There's something called a SNAP regimen, which again gives a 300 milligram per kilogram total dose, but they just give it in a separate manner, like a two bag method. So that is, they give uh, fif- uh, 50 milligram per kg per hour for 2 hours, followed by 20 milligram kg per hour for 10 hours, and it generally again comes to around the total 300 milligram per kg. In general, whatever dosing regimen you feel comfortable with at your center, you should use that, and this is the most common dosing regimen that I've given. What about dialysis? Dialysis, these are the extreme guidelines, and this is a bit complicated, but basically, what I want you to remember is that if the levels are more than 900, and the patient is having altered sensorium, and the patient is having metabolic acidosis, that is when you consider patient for dialysis. So levels more than 900, altered sensorium, and acidosis. And dialysis, remember, is not an alternative to NAC. No, NAC still has to be given, and actually, the dose of NAC has to be increased in patients who are undergoing dialysis. And another thing that I forgot to mention is that what do you have to do if the patient is having a massive ingestion of paracetamol, like more than 30 grams? Patient is having severe metabolic acidosis and ultrasensorium within the first 24 hours itself. In that case, it is suggested to modify the NAC regimen somewhat, and the infusion rate, the third infusion rate, you should actually double that. So that is what is given in up to date. So the third infusion rate, the speed of NAC is actually doubled in very massive ingestions of paracetamol. But again, I would recommend you to consult with your seniors before you actually, if you're actually facing that kind of specific scenario. And okay. So, and ultimately, we have some criteria for liver transplant in these patients, like modified King's College criteria. And it's actually, we have very high sensitivity specificity, both more than 90% for requirement of liver transplantation to improve survival. So either the pH is less than 7.3, or all three of the creatinine more than 3.3, He at least grade 3, and INR more than 5. So if this is fulfilled, the patient is a candidate for liver transplant. Or obviously, this is not a decision that is going to be made by one person. You're going to have an entire team to actually, take a call on something like this. And this is not going to be decided in the emergency department. This is more of an ICU level thing. And if you have difficulty remember in this, just try to remember the threes. So 7.3, 3.3, HE3, grade 3. So in summary, so basically, there N-acetylcysteine is having a huge mortality benefit in paracetamol toxicity, and it's better to start it earlier for maximum benefit. And if even if the patient is presenting a little late, then just start the patient on N-acetylcysteine. So you should have a very very low threshold to start the patient on N-acetylcysteine. That is the take-home point that I want to give everyone. And the important thing to remember is that even with the 21-hour infusion, you don't stop the infusion after the 24 hours finish. You have to actually meet the specific criteria for stopping the NAC infusion. If the patient doesn't meet that criteria, you have to continue the patient on NAC. So that that, that was all about paracetamol poisoning. And if someone has some doubts, you can ask now. Or otherwise, I'll move on to massive hemoptysis.